Host now. All right, I'm recording as well.
We are recording as well.
Yep. So, are there questions from last time? Very brief, or shall we go ahead? I'm going ahead.
Let's go ahead.
So, let me put up some slides here. And let me share my screen. Okay.
We needed.
Okay, so today we're going to talk about building the team. We've talked about types of integration, and we've talked about why you would do all this, and hopefully I'm helping, or the whole process is helping you feel more comfortable and assured in making the case for people. But when it comes to doing the transformation, making the team, often people don't know where to start. So here's some ideas. The role of leadership is really important. My experience of integration was what you might call backdoor integration, which is that you get a behavioral health person in the practice, and over time, they essentially seduce the practice into integration. They gradually convince people that it's important. Over time, they put up with all the ways that they sort of get marginalized or don't feel a part of things. But in the long run, they've helped enough people and they get enough credibility so that things can tend to move along. That is an inefficient way to do it. And ultimately, medical practices, like many organizations, are much more top-down than bottom-up. And so being clear that leadership is important, and that the leadership is going to need to be not just tolerant of integration, but leading integration, leading the adding of behavioral health for the benefit of the patients. Remember, always go back that this is for the benefit of the patients, or in a teaching practice that this is for the benefit of the patients and the learners, but not that integration is so important. It's about better care. So they need to articulate better integration as a core value of the organization for better care. It helps to have a designated core group that are working on this process, and that the core group is made up of different elements of the practice. So not just the physicians, but a representative, what you might call a lead from each of the elements. You'd like to make the new model more appealing, and you always have the fact that it takes the pressure off physicians when it's done right. That across the board, when integration or when you add behavioral health, it is the most immediate outcome is doctors liking to go to work more and liking to deliver care more, because they were already delivering care to these folks. They just were frustrated that they didn't feel like they were doing a very good job. So it means you're going to need to commit the time and the resources, and the time and the resources is mostly about meeting. about learning together, about talking about things and exchanging information. And then you're going to need to keep track of staff reactions, because there are going to be places where it's inconvenient. And somebody, probably somebody from the core team, is going to need to be out there addressing that. And you don't want to be pushing too fast. You want to keep people's spirits up by being able to congratulate them on what they're doing. The mission is important. I have to say that it's not always something that just turns people around. Docs still tend to feel like this new person is, aren't they going to be a complication? Isn't this going to be a time suck for me? I'm not used to doing this. It can't be better, because, I mean, I'm going as fast as I can now. That's a typical reaction. I'm going fast as I can. I can't go any faster. And someone else can say, you know, we're going to try and work smarter and not faster, but they don't know what smarter is. And so it feels like, no, this is just another excuse for faster. So also they tend not to have any clue about how behavioral health can be used more broadly in the practice besides addressing depression and anxiety. They're already pretty sophisticated if they even think of behavioral health when they're talking about substance abuse. So mostly they just think depression, anxiety, get them over there. Often what they would like to do is to say, yeah, that would all be well and good, but I'm not really sure what these behavioral health people do. Docs often don't know any more about what behavioral health people do than somebody would who watched television, and the representation of mental health and substance abuse help on television isn't particularly complex or flattering. And so they often will say things like, you need somebody to talk to, like maybe that you need a friend, or you need to get to the bottom of this, that maybe you'll just tell the bad thing that happened and it'll be better. That's certainly how it works on TV. Even though they would like to do that, it's not going to work, because referring has probably already been a failure. If you highlight how much people know about which referrals have been a success, and how often people get what anybody would call treatment in specialty mental health, they're going to say, no, it doesn't happen very much. They don't know when people start treatment. They don't know when they drop out. They don't know what was being worked on. They don't know why it's better. And so really, they're going to have to do it in-house. So having a physician who's championing this can make a lot of difference. And so that person not only represents integration to the other docs, but they represent the reactions of the other docs to the sort of team that's working on integration. And so it can help people know when to go slower or when to go quicker. Often non-physicians will think, well, if we just do this, it's going to go faster. And physicians, because they're the ones who've been sort of the core of the workflow up to now, the workflow has been around their needs. They say, no, that's not going to work. And so you're going to have somebody to express that in the room where you're trying to work these things out. Because if you try and implement something that all the docs look at and say, that's not going to work, then you've completely lost credibility. So here's the core team. So administrative lead, a physician champion, a behavioral health lead, a nursing lead, care management lead, an office administration lead. It doesn't have to be this group. every practice is a little different, but that's an example of some core group that's sitting together, working on what to try next and how to go forward, and getting back feedback for how it's going, and who can then distribute information and talk about the mission and why we do this to each of their constituencies. Now, we've talked about this before, if you've heard me talk much, that going out and just hiring a mental health professional is generally not a good idea. That primary care behavioral health is a challenge for them. It's a different population than they've been seeing in their mental health practices. These people are less disturbed and less diagnostically clear. They, by and large, won't accept mental health or substance use disorder as the definition of their problems. I mean, if you go to a mental health center, you're sort of tacitly accepting that mental health is what you need, even though a lot of people come in the door denying that. At least you win. In primary care, one of the reasons we're doing it this way is so they don't have to accept mental health. That isn't necessary to get better. And so, all right, I think we're back.
Yes, we can hear you now.
Okay, good. So I'm sharing my screen again. There's a much broader array of things you have to address in primary care. You have to learn about medical things. If you're not able to explain to somebody and ask somebody about their diabetes, you're not really on the team very well. You're a member of the team. In most cases, you're not the leader of the team. And then the whole issues of going faster, that's a challenge, of sharing with the team information which feels like a violation of confidentiality, and of trying to get something done every day. So I want to add value to anybody's day that I work with, teach them something, offer them something, not just meet them and then ask them to come back later. In fact, it takes more training to do what we need to do. We have to be able to address a lot of different, or do a lot of different kinds of services, at least on a generalist level. You don't have to be the best relaxation or hypnosis person. You don't have to be the best family therapist. You don't have to be the best at substance abuse engagement and counseling, but you have to be able to do the same level of quality work on those that your primary care colleague can do on things like heart disease, which is they can take care of most of the heart disease they see, but there's a percentage that is too severe or that needs a specialist. Well, you're in the very similar role. Then there's the whole question of who should we hire to do this, because if somebody hasn't already been trained, how do I know what to do? And I would say, first of all, if you're going to have somebody who hasn't been trained in primary care, hire by personality and then train them. And by personality, I mean somebody who is generally upbeat. They are anxious to get out and meet people. They are curious, enthusiastic, and flexible. And then you send them to a training program. And the program at UMass is one possibility, but there are 3 or 4 others that might work for you. And all of those are on the New Hampshire Primary Care Behavioral Health Workforce site, if you're interested. Then there are these other folks on the team that you have to think about. We call them care enhancers, but they are care manager, care coordinator, navigator, health coach, advocate, community health worker, all these various roles that aren't physician and aren't behavioral health, and that are different in different settings. So if you know what a care coordinator does in one setting, that does not tell you what the care coordinator does in the next setting. So these all folks are starting to have a behavioral role to some degree. They do things like maintain engagement and care, address issues of health literacy, address social and economic barriers, the social determinants of health, and keep information flowing back and forth with the patient. All of those are important. And a care manager, who, when they are the ones who are also connecting people with resources and so forth, often are a person who gets resource lists and resource connections for the practice as a whole, and enables everybody to do a little bit more care management for their patients, because the care manager can't do everybody. Same thing with the behavioral health person. You get resources, you help orient people to behavioral health interventions that they can make even without being a therapist, and because you can't see everybody and do everything. When we're talking about building the culture of a team, one of the things to say is, if it's possible, continuity of the team makes a big difference for physicians. If they have a different nurse, a different medical assistant, different care manager every time they come to work, they don't bond. It doesn't really become a team. They begin to get connected to this team and to be able to feel like they're helping the team, and that's their team, when they do it regularly. This is a challenge for practices. It doesn't come easily, but because people are part-time and they go out on leave and so forth. But if that's a value, and that's an important value, what you find is that the teams begin to coalesce. And then the doctor is sort of the default leader, except on times when someone else needs to be the leader. And so doctors don't need to be committed to always being the leader. That's not a good model, because there are times for some patients where the care manager really is the leader. But the doctor, using a little bit of mission talk, talking about what we're here for, being interested and appreciative of how the team is doing, can do a lot to make this team begin to have some important team culture. And then as they work together, and you have to look for times when people work together. So the huddle, the meeting, it's good if it's a weekly meeting where they talk about difficult cases. Any kind of QI that they do together, where they get together and say, oh, our data says that we're not addressing this very well. Let's do a PDSA. Let's try to do something a little different with these patients this week, and then see how we're doing next week. That kind of thing creates a team culture and pride, but it also increases expertise, because as they talk about their patients from each of their perspectives, other people gradually learn some of that expertise. Huddles, like I said, I think are really important, and they don't come easily. Docs often say, well, I don't have time. I just don't have time. In my experience, huddles start to happen when the leadership says they're gonna happen. And once the leadership gets committed, it becomes a routine and a ritual, and people do it. So it needs a clear agenda. In my practice that I was at, there was a list of things we did. There was a huddle agenda, default agenda, and they were coated in plastic, and they were sitting on various surfaces. So anybody could run the huddle, because they could pull out this agenda and go through it. Team members need to know what information that they feel empowered to get the information that they're going to need from others to do their job in this half day. You tend to have a huddle before each half day. It saves time. It minimizes waste. And as soon as it starts to work, people get committed to it. It is true, whether or not you can make it happen, that teams build also when they're not just doing work. You know, if the team has to have lunch together to talk about something, that is a great way to build connection. I don't think that they're going to go meet each other every Saturday to go roller skating, but I think that moving it off the clinical hall a bit can be very useful. The QI data, the team should get its data about its patients monthly so that they can work with it. And to make a team work, it requires clear empanelment, meaning the team knows who their panel of patients are. And if they're always taking care of other patients, if there's a great deal of switching between teams, that's going to make the whole thing harder because they won't have the continuity with their patients. This is generally an idea about feedback, that as the team coalesces, you'd like them to be able to share feedback. And feedback meaning what the other person did well as the first criterion, and then to be able to say, you might want to try so-and-so. And as that happens, people can get from the idea that this is a correction to this is an idea that's a help. In fact, it's possible on really well-functioning teams for lower level people to call upper level people to step up. You let us down. When you came 10 minutes late, all of us had to wait. That takes a lot of trust, but when it happens, it can be very helpful. The metrics from QI, I'm not going to go into this much, except to say that in many practices, as people start to do more metrics around QI and follow more things, keep track of things when they get EPIC in there, or some other EHR, they call on researchers to come in and help them design how they're going to capture the information. And the researchers can be a problem because they always want more. I can't tell you how many meetings I've sat at where somebody says, well, you know, it would also be really interesting to know if they're coming from the east side of town or the west side of town. Maybe we'll set up categories for that. And so obviously that may be a silly example, but it means that what you're going to capture gets bigger and bigger and bigger, and in the long run, it's too complicated. And the whole QI thing starts to fall in on itself. Same thing with measures like the PHQ-9. People will often say, well, we've got the PHQ-9, but we also need a measure for postpartum depression. And we also need a special measure for adolescence. And we also need a measure for vocational functioning. Well, the PHQ-9 is sort of a rough and ready measure but it's correlated to all those things and has been shown to be valid for postpartum depression and is shown to be useful for adolescents. So you want to find measures that are as broad as possible and not keep adding on new measures. Workflows for integrated teams tend to be scaffolded by the process of screening. So as soon as you're screening with depression or with anything else, you'll find that that solving the issues of screening will demand a rework of the workflow. So who's going to hand the person? First, how will you know that this person should be screened today? Who will give them the screen? How will it be administered? Who will score the screen? Who will follow up with the person? All of those, how will that results be entered into the EMR so that they can be collected? Because if it goes into the note as part of the note, it's gone. It's useless. It's going to need to be in a flow sheet. And so as you solve these and sitting with a team and talking about it with them and facilitating this conversation and getting to what they want to try this week, and then they come back and you try something else and so forth, that all of the process there of making that screening work smoothly is a reason that kind of opens up the flow of care in general, unlocks the current workflows. And so then you can look for ways of improving other things during that process. And another piece of doing this transition is that helping the patients be part of it. That means that they need to know that the practice is getting this behavioral health service. And it helps to have a brochure, or a flyer, something that says, this is our behavioral health service. You want that flyer not to talk about mental health, to talk about helping people learn skills to cope with their illness or their stress, or how about reducing stress, about meetings rather than therapy. You want to highlight that the behavioral health clinician is part of the team. Sometimes people have outreached through phone calls and mailings to ask people about, have they heard about it, or what kind of interest in issues they might have. But you don't need to do that. You can just be sure that people know. And it also allows the doc, because then if the doc wants to recommend behavioral health, but not today, they have a flyer they can hand to the patient. That saves a lot of time, and it says it the same way every time. You don't get this big variation about how docs talk about it. I threw this one thing in that you might teach them that some of you may have heard because you've heard me before. But the whole SSRI mnemonic, and it's for passing the relationship within the team. So when you have one team member, usually the doc, with the patient, how do they bring in the next team member? What do they say about this person? And so S is for situation. What's the situation in the patient's care that makes the current team member, the doc, for instance, want to involve the behavioral health clinician? Skill set. What's the skill set of the behavioral health person or of the next team member that fits this problem, this issue that we're trying to help with? This was an example of that in a note. This is a real note. Kathy would like to be in better control of her emotions. She gets angry often when people are mean to her about her weight. She's 15. She can't talk to her mother. She would agree to counseling as long as the counselor is not all nice and happy. Refer to Dr. Blunt, who is neither nice nor happy. That's somebody who knew the drill, right? My skill set was just what that 15-year-old needed. And she came and she worked with me, and we did very well together. The relationship is, what's the relationship of the work you're going to do with the next team member or the behavioral health clinician to the overall treatment? Not what kind of relationship are you, the patient, going to have with this person. And the indicators are, what would indicate that adding this next team member was useful, was doing what we hoped. So I'm going to give you a couple of examples of the SSRI. So here's one. The doc says, for situation, the doc says, Ms. Ruiz, let's imagine the behavioral health person is there now. Ms. Ruiz has terrible headaches. I think they may be related to stress. Dr. Collins is an expert at helping people cope with stress. Relationship. I'm hoping that Dr. Collins and you can look into the sources of stress in your life and see what ways of reducing or managing the stress you two can develop. That would help me decide if it would be possible to avoid an increase in medication that I think would be safer to do without. And the indicators, because Ms. Ruiz was working successfully for quite a while, even though she was coping with headaches. I suspect that if she can get a bit of control, even a small reduction in the frequency of her headaches, she'd be able to go back to work. That would be a significant difference for her family financially and would further reduce the stress she's facing. So you can see this is a very short statement. This is not a long time, but it covers those bases. Here's one more and then I'll let you go. Situation. Ms. Smith is having a very difficult time helping Brandon settle down at night. He's 3. It's stressing the entire household. Introducing the behavioral health person. Ms. Johnson here is a person with a lot of experience helping parents successfully manage bedtime. Relationship. I'm hoping that working with Ms. Johnson, you can find a way to reduce the stress of bedtime. Ms. Smith has been having a difficult time managing her diabetes, as shown by her very high hemoglobin A1C, and the stress at bedtime is certainly not helping. So that's the relationship. This is helping with mom's illness and with mom and the whole household stress. And the indicators, because if Ms. Smith could get Brandon to bed reliably in under an hour, she could return to exercising in the evening. That would be good for her lipids, her A1C, and her peace of mind. So we've talked about in other settings, I think, about how you may have to work on your words a little bit to be able to talk in front of the patient. But it's definitely better to have that as a way you do than to go in the hall all the time and then come in. Using the SSRI in the room with the patient helps you pass the relationship among team members and ultimately helps solidifying the team. And that's the end of this little lecture, and I'm going to stop recording.